Welcome back. So previous video in CNS, we had covered benzodiazepines. That is, we went through the sedatives and hypnotics. So now we'll be moving ahead. So here we'll be talking about the general anesthetics. So as we look into general anesthetics, first we'll know the classification. Under general anesthetics, main thing is firstly inhalational we have, and also the parenteral. So mainly we'll be focusing only on the inhalational. So there is volatile and gas. Under gas, the main one is nitrous oxide. So under volatile, halothane, isoflurane, desflurane, sevoflurane, and ether. So the mnemonic would be HYDE. Okay, so H for halothane, I for isoflurane, D for desflurane, E for ether, and you can add an S for sevoflurane as mentioned. So in this video I'll try to go a bit fast because I assume all of us will be aware of these basics. So now moving further, we'll be discussing about the inhalational only. Under that there is halothane. We'll just give a short note on what is halothane. Halothane, it is nothing but a volatile liquid. Okay, some of its adverse effects are important, and note that most of it will start with the letter H. So it is hypotension, results in hypotension, can be hepatotoxic, and in the heart, it affects the heart and can result in arrhythmias. Okay, and also can result in respiratory depression. Okay, now if we just generally look at the properties of anesthetic, inhalational anesthetic. So while giving an inhalational anesthetic, the point that has to be noted are the margin of safety, the recovery time, and the induction time, the amount of analgesia it can produce, and the sensitization of the myocardium, and whether it's hepatotoxic, about the hepatotoxicity, then any irritation to the respiratory tract, and to check for other common effects such as nausea and vomiting, post-operative nausea, vomiting, nausea and vomiting. Now moving ahead, we'll be looking at a drug known as Tripendone Sodium. Tripendone Sodium, yes. Okay, now looking at Tripendone Sodium, it is an ultra short acting barbiturate. It's ultra short acting, and it is also given for induction of anesthesia, and it is highly irritant, highly alkaline as well. So it's highly alkaline and also irritant. Okay, and other important thing is that it enters highly perfused organs. Okay, enters highly perfused organs such as the brain, liver, heart. Moving ahead, looking at the use of Tripendone sodium. The use, it is used for, as mentioned earlier, induction of anesthesia. So induction, and then it can be used as anticonvulsant. Okay, and then it can also be used in narcoanalysis in psychiatry. Okay, now looking at the advantages of Tripendone sodium. So what is making it special? So there's rapid induction of anesthesia and rapid recovery. So there's rapid induction is present, and also there's rapid recovery. Okay, and another important point is that it does not sensitize. So it does not sensitize the myocardium to the circulating catecholamines. Okay, now moving ahead, we'll be looking at the disadvantage as well. So let me just make a column. So we told about the advantage. Main thing, it is rapid. Okay, what is rapid? Rapid acting and rapid recovery, and then does not sensitize. I'm just writing the keywords to make it short. And looking at the disadvantage, as we mentioned, it depresses the respiratory center. So there's depression of respiratory center and also the vasomotor center. Okay, respiratory center, vasomotor center, and the myocardium. And it is a poor analgesic, gesic, as well as poor muscle relaxant. Okay, and it causes laryngospasm. Okay, and it also precipitates acute intermittent porphyria. So increases acute intermittent porphyria, and this, if you remember, it was also discussed in the previous video. So now moving on, just highlighting on benzodiazepines as a short note. Just giving a few points, that is, under this you have diazepam, lorazepam, midazolam. Okay, so what happens is it delays recovery and prolongs amnesia. Go back. Okay, so delays recovery and provide amnesia. It has a poor analgesic effect, and an important point to note is that it does not cause nausea and vomiting. So does not cause nausea and vomiting. Okay, and it is useful in endoscopies. You can use it in endoscopies and fracture reduction as well. Okay, now moving on further, looking at a concept of preanesthetic take medication. Okay, so there is a concept of preanesthetic medication. Here there are drugs that are used before the administration of anesthesia just to make it safe. Okay, so here I'll just quickly highlight the points. That is, it decreases the anxiety, apprehension, and also vagal bradycardia, cardia, and also the saliva secretion. Okay, and also the reduces the pre and post pain, operative pain, antiemetic effect, and also prevent acid secretion and stress ulcer, and also to hasten gastric emptying before the surgery. Okay, so hope I was clear. So decreases these, decreases the pain, acid secretion, and also the stress ulcer is reduced, and gastric emptying before the surgery. Now moving further, we'll be looking at a concept of alcoholism. Okay, so here what's happening is we'll be looking at disulfiram. Okay, so firstly let's see what happens to alcohol. See, alcohol, when it's taken with the presence of alcohol dehydrogenase, okay, so it's converted to acetaldehyde. Done. And then in presence of aldehyde dehydrogenase, it is converted again to acetic acid. Okay, so here this is disulfiram. Okay, so this disulfiram, it inhibits the alcohol dehydrogenase. This process is inhibited, this step, and causes the accumulation of acetaldehyde in the blood. So due to this, acetaldehyde is accumulated in the blood and tissues, and leads to something known as acetaldehyde syndrome. So these, in case of acetaldehyde syndrome, we'll just know a few points of what exactly the patient presents with. So in case of acetaldehyde syndrome, the patient can present with nausea, vomit, flushing, headache, tachycardia, palpitations. Basically, whenever you're nervous, whatever happens, the same thing is happening here. So you have headache, sweating, tachycardia, palpitation, breathlessness, chest pain, hypotension, hypoglycemia, confusion, shock and death. Shock and death. Okay, now moving further, we'll be looking at the methanol poisoning as well. So here we have methanol poisoning. So this mainly occurs when the spirit, methylated spirit, is consumed. Okay, and methanol is a mild, what we need to know, it's a mild CNS depressant as well. Okay, so now I'll just try drawing a flow chart so that it's easier. So exactly we'll know what happens. So methanol is converted to formaldehyde. So this formaldehyde is again converted to formic acid. This formic acid is converted to respiratory depression and acidosis, and also can result in the retinal damage. Okay, so on the other hand, if you look at ethanol as well, ethanol is converted to acetaldehyde and is converted to acetic acid, just as we saw earlier. So here both places we have alcohol dehydrogenase. Here as well there's alcohol dehydrogenase. Okay, so the treatment would be by, there are a few steps which are followed in case of the treatment. So the patient's eyes are protected from light. So first we need to protect from light. Okay, and then the airway, breathing and circulation are looked after. So this is commonly known as ABC, airway, breathing and circulation. And also the gastric lavage can be done. Okay, and then intravenous sodium bicarbonate can be given for acidosis. So sodium bicarbonate given for acidosis, and also to prevent the retinal damage as well. Next, ethanol is also added, ethanol administered, and this is by nasogastric tube. So because this ethanol is added, let me just go back. So here the same flowchart is followed, and here as well for ethanol. So what happens is that there is a competition between them, and because of this, what happens is the formation of formaldehyde and formic acid is reduced. So this decreases the formation of formaldehyde and formic acid. Okay, and then what happens is the methanol is excreted in urine and also the breath. Okay, now just looking further, like how is methanol poisoning treated. So we are looking at methanol poisoning. So here a good point is about fomepizole. Yes, fomepizole is nothing but a alcohol dehydrogenase inhibitor, and we had a discussion on this in the group, and it is a very expensive drug, very expensive. Now looking further, we have also calcium leucovorin, which can be administered. Okay, so what this happens is it enhances metabolism of formate. Okay, and decreases its level, and hemodialysis is also done to promote excretion of methanol and toxic metabolites. Moving further, we'll be looking at an important anti-epileptic drug. Okay, so this is a very important anti-epileptic drug, and it is known as phenytoin. Okay, so it is the most common, very common, and the main point is drowsiness is not usually produced. So there's no drowsiness. So chances of drowsiness is very less. Now just looking at the mechanism of action of phenytoin, and I have discussed this many times, but I'll repeat it again. So there is something known as voltage gated sodium channels. Okay, So there is presence of voltage gated sodium channels. So this phenytoin, it binds to the voltage gated, voltage dependent sodium channels, and what happens is it prolongs the inactivation. Fine. And because of this, the entry of sodium is prevents entry of sodium into neuron. This is an important point. So what happens is this ultimately it results to reduction. I'll just do it in the next slide. So as mentioned earlier, we told that there's decrease in sodium entry. So this results in reduction in intraneural sodium concentration, and leads to membrane stabilizing effect. And this again, it leads to inhibition of repetitive AP, that is nothing but action potentials, and it reduces the seizure discharges, and decreases the high firing. So this is how it is. So let's just recap. So as mentioned, the phenytoin, it acts on the voltage gated thing, and it prolongs the inactivation of the channel. This because of this, the sodium entry is prevented, and this ultimately it results in inhibition of generation of repeated action potentials, and due to this there's inhibition of high frequency firing. Fine. Now just looking quickly at the uses. So phenytoin, where is it used? So phenytoin, it can be used in general tonic-clonic seizures, partial seizures, trigeminal and other neuralgias, and status epilepticus. Now moving further, we'll be looking at the adverse effects, and this I have repeated a lot of times because it's very, very important. And main things, everything starts with H. So we have hypertrophy, there's hyperplasia of gums, and then there's also hypersensitivity reaction, there's hirsutism, hyperglycemia, hypokalemia, let me just, I left with hyperglycemia, and because it's hyper, there's another hypo, that was hyper, this is hypo, so it's hypocalcemia. Next is FHS, this is nothing but fetal hydantoin syndrome, and there's also osteomalacia. Done. Now looking at very high concentration, it can also lead to, in case of a CNS manifestation, it can lead to vestibulocerebellar syndrome. So what is this? It mainly includes vertigo, ataxia, tremor. So now looking at CVS, it can result in hypotension as well as cardiac arrhythmias. And looking at GIT, it can result in the common, that is vomiting, nausea, dyspepsia. Now that was over. Now quickly looking at the pharmacokinetics, it is absorbed slowly. So pharmacokinetics, so absorption is very slow in the GI tract, and it's highly bound to plasma proteins. So plasma protein bound, okay, and is highly bound. Done. Now it almost completely metabolized in the liver. So it's metabolized in liver by the process of hydroxylation. This is important, hydroxylation and glucuronide conjugation, okay, and the repeated administration of phenytoin, what happens is there's increase in rate of metabolism of the co-administered drugs. That is an important point to note. And elimination is by first order kinetics, okay, and looking at the plasma half-life, it is about 12 to 24 hours, that is T half. And kinetics, it can change to 0, okay. Moving ahead, we'll be looking at carbamazine. So carbamazine, so it is nothing but a TCA, that is tricyclic antidepressant. Now moving quickly to the MOA, mechanism of action. What happens is there is a slow recovery of sodium channels from inactivation. Same is the mechanism of action. So reduction in, okay, so there is reduction in recovery time of inactivation of sodium channels, okay. Now quickly looking at the uses of carbamazepine. So it is commonly used in anti-epileptic as we are dealing with it, okay. So it is a drug of choice in case of the general tonic-clonic seizures as well as SPS and CPS, that is simple and complex partial seizures. And it is a drug of choice in case of trigeminal neuralgia. These all are common uses, neuralgia, and in treatment of acute mania also it is used, and also bipolar disorder, okay. Now quickly moving ahead with sodium valproate, okay. So just I didn't mention the adverse effects, and here it's also common. So there's sedation, there's drowsiness, okay, and also there's ataxia, there's diplopia here as well, diplopia and vomiting, confusion, okay. And looking at the quickly highlighting on the pharmacokinetics as well, a few points. It is absorbed slowly and erratically, okay, in the GIT, and it also binds to plasma protein, and it is metabolized in liver, okay. And now moving ahead with the drug I was supposed to talk, that is sodium valproate. Sodium valproate is a broad spectrum, okay, it's a broad spectrum anti-epileptic drug, okay. So it's a broad spectrum anti-epileptic drug. And quickly looking at the mechanism of action of sodium valproate. So what happens is, again, there's a delay of sodium channel recovery from inactivation, from inactivated state, okay. So next, there is also this blockage of T-type calcium current in thalamic neurons. Okay, there is blockage of T cell, and this is similar to the ethosuximide. And also there is increase in GABA activity in the brain, and this can be by increase in GABA synthesis, by stimulation of GAD, that is glutamic acid decarboxylase, and also decreased degradation of GABA by inhibiting GABA T, that is transaminase enzyme. So decreased degradation of GABA by inhibiting the GABA T enzyme. Now quickly highlighting on the uses. Yes, it is effective in absence, myoclonic, and partial, that is simple partial seizures and complex partial seizures, and also generalized tonic-clonic seizures as well. And other uses can be in mania and also in bipolar disorders. It can be used. Okay, and moving ahead, also in migraine. So sodium valproate can be used in migraine as well. Now quickly looking at adverse effects. So here there is a very good mnemonic, that is again the valproate. So it can result in, so let me write valproate and see what fits in. Okay, so V for vomiting. So there is also anorexia, and there in the liver, if you see, there is hepatitis. Okay, and it can be teratogenic as well. There is ptogenicity is found. Okay, and you can find rashes, alopecia, and pancreatitis, teratogenicity. Okay, so most of it is covered. That is vomiting, anorexia, you have hepatitis, and can also result in pancreatitis, rashes, alopecia, teratogenic. Okay, and now just highlighting on the pharmacokinetics. Valproate is rapidly and completely absorbed in the GI. So it is almost absorbed in the GI, and it is plasma protein bound. Okay, and it is metabolized in liver and excreted in urine. Almost most of the drugs, majority of the drugs are metabolized in liver and excreted in the urine. So it's a common point everywhere. Now moving ahead, we'll be focusing on the opioid analgesics as well. So quickly going through what the opioid analgesic is, and I will just finish off with this topic. I don't want it to be very long, so it will be very difficult to focus as well. So I will be just covering the last topic, that is opioid analgesic. Okay, so we'll be looking at opioid analgesic. So the most common drug we all can think of is morphine, very common. So it is obtained from Papaver somniferum. Okay, now just quickly looking at the classification is very, very, very important. So opioid agonist, there is natural. Under natural opium alkaloids, there is morphine, codeine, thebaine, noscapine as well. Now looking at semi-synthetic opiates, under this there is heroin, pholcodeine, hydromorphone, oxymorphone. Okay, then synthetic, there can be pethidine, tramadol, tapentadol. So these are just a few I have been naming. So there is also opioid agonist. Let's go further. There is opioid agonist. So since all of you would have already revised the notes already provided, so I think I'll just go fast. So opioid agonist antagonist, there is pentazocine, butorphanol. Okay, now looking at partial mu receptor agonist and kappa receptor antagonist. So here there is buprenorphine. Okay, buprenorphine. Now just quickly looking at some important points of morphine. Okay, so I'll just try depicting in a diagram. So now looking at morphine, so what does it relieve? So it relieves pain. So these points are very important and it's very easy. So fear, anxiety and apprehension. Okay, and also the sickness, the feel of being sick is reduced. That is, there is a euphoric effect as well. So euphoric effect is produced. Now looking at the effect or the action, it can result in, this is very important, it can result in meiosis, analgesia, respiratory depression, physical and psychological dependence, and also histamine release and can result in hypotension and as well as hypothermia, can result in itching, can result in nausea and vomit, can result in euphoria as well, can result in cough suppression, there is constipation as well, and there can vagal stimulation, and there is bradycardia. Okay, and sedation and hypnosis. Just to recap, there is meiosis, analgesia, respiratory depression, there is physical and psychological dependence, histamine release, hypotension, hypothermia, there is itching, there is nausea, vomiting, euphoria, cough suppression, constipation, there is vagal stimulation, bradycardia, and also there is sedation, hypnosis. Okay, so these are some important points that needs to be known. So just again I'll just present again. So there is morphine. So this morphine, it can result in depression of the VMC, okay, vasomotor center, and can also result in histamine release, okay, histamine release, and can also produce a direct action on blood vessels as well. Okay, and all these three, that is depression of the VMC and histamine release and also the direct action on blood vessel can result in vasodilation, and this vasodilation, it results in hypertension. Okay, so that is done. And now quickly going through the adverse effects. Most common, that is nausea, vomiting, constipation. Okay, constipation is there. And then there is again decrease in respiratory, there is respiratory depression, there is again hypertension, there is drowsiness, confusion, as well as there's mental clouding. Okay, and as mentioned earlier, there can be itching and skin rash as well, skin rash. And also there is difficulty in micturating, so there is difficulty in micturating as well. Okay, and the seizure threshold is lowered as well, threshold is lower. Okay, so I'm just going in a faster pace, assuming we know most of it, and in case you want me to go slow, please put it in the comments, otherwise I'll continue being in the same speed. Now another important concept is, yes, so I'll just finish off with this. So another important concept is morphine poisoning. Okay, acute morphine poisoning. So we had already discussed some few poisonings back. So how do you manage this? So first thing would be to hospitalize. Okay, so before doing all this, there's a classic triad which has to be noticed. So that will be nothing but respiratory depression will be there. So there's respiratory depression, and also there's pinpoint pupil, and also there can be coma. So these are some of the important triad, that is respiratory depression, pinpoint pupil, as well as coma. Now other signs which can be seen in case of acute morphine poisoning can be cyanosis, hypertension, as well as shock and convulsions. Okay, now looking at the treatment, the main thing, as we know, it can be hospitalized, should be the first priority, and then ABC should be seen. This is very important. Airway, breathing and circulation, and ventilatory support can be given, and gastric lavage can also be performed, gastric lavage. And also there can be a specific antidote, that is nothing but naloxone. Okay, so this is nothing but an antidote, okay, can be administered, and it should be done with caution, because there can be severe withdrawal symptoms as well. Severe withdrawal symptoms can also be noticed. Okay, now just to quickly contraindications. So this we're talking about morphine, where should it be contraindicated? This is a very important point, and in practice as well. So it is contraindicated in case of head injuries. Okay, because there can be vomiting, meiosis, and mental clouding. So these things, they interfere with the head injury in the case of a head injury patient. Okay, so in case of assessment, it plays a major role, and the assessment cannot be done pretty well in case of these effects, that is vomiting, meiosis and mental clouding. Now another point to note is morphine can result in respiratory depression. Okay, and can result in carbon dioxide retention, and can result in the cerebral vasodilation, and can increase intracranial tension as well. Okay, so let me go again. So morphine, it decreases the respiratory depression is seen, and the CO2 retention is seen, and cerebral vasodilation, and increase in intracranial tension. Now we'll just see opioid, just recapping the entire thing. So morphine, it is nothing but an agonist, and naloxone is nothing but an antagonist. Okay, this is an important point that I discussed here, so that needs to be known as well. Now moving ahead, what do we have? The contraindications. Yes, we'll still continue the contraindications. So as you can recap, I have told that it is not supposed to be used in head injury. Okay, and also in case of bronchial asthma, and also in case of COPD and hypertensive state, also in case of hypothyroidism and hypopituitarism, and in case of infants as well as elderly, it can result in severe respiratory depression, so it cannot be used. It should be used with caution. And also in case of undiagnosed abdominal pain as well. Okay, so till here it's done. I think I'll stop with this. So in case you find the speed comfortable, let me know. Or in case you're not happy with the speed, you want me to increase or decrease, that too you can let me know in the comment section. So thank you. In case you like the video, please give a like, and see you in the next video. So thank you for watching, and bye.